Okay, in the interest of time, I'm going to go ahead and get started. I'm going to go a little bit quickly just so that we can keep on schedule. But if you have any questions or something is not clear, feel free to write it down on one of the cards and we'll go over it during the Q&A, okay? So the first thing we need to talk about is what does it mean when we say adjuvant therapy? So what that means in terms of treatment is it's a treatment after the cancer has been surgically removed that can help lower the risk of it coming back. And that means either coming back in the original location or coming back somewhere else in the body. For melanoma, we generally consider stage 2C and stage 3 patients eligible for adjuvant therapy. But not every patient with a stage 2 or a stage 3 melanoma needs adjuvant therapy. So radiation is one form of adjuvant therapy, and this is where a radiation oncologist would administer some particles to your either surgical site or your lymph node basin. For melanoma, radiation is considered a little bit controversial. Again, not every patient that has their melanoma removed needs radiation. But some indications include patients whose melanoma begins on their scalp or in their neck region, melanoma that originates in your mucous membranes. If someone has more than 4 lymph nodes involved when they have a lymph node dissection, we consider those patients for radiation. Melanoma that extends beyond the shell of a lymph node, we call that extracapsular extension. Those can be considered. And then oftentimes we think of patients who have a deposit in their lymph node greater than 3 centimeters, so something kind of large and palpable. Another small consideration sometimes is if we see on a pathology report that there's involvement of the nerve fibers, then we consider radiation. But there are no real hard and fast rules, particularly because of some of the complications of radiation. Besides radiation, there are other options for adjuvant therapy, and this includes interferon, biochemotherapy, or traditional chemotherapy, and then some of our newer agents, Ipilimumab, Vemurafenib, and then vaccines. Generally, those are on clinical trial. So interferon was approved almost 20 years ago now, and it was on the basis of this clinical trial. It was a study that took 287 patients with stage 2C or stage 3 melanoma that had been removed surgically. And patients were randomized to one of 2 treatment arms. In the first treatment arm A, they were just observed for the first year, and they had their routine scans and blood work performed as well, but they had no treatment for adjuvant therapy. In arm B, patients received induction interferon followed by maintenance interferon, and this regimen is generally referred to as high-dose interferon. On the basis of these results, interferon was FDA approved for the adjuvant treatment of melanoma. So in patients who were observed, their average time to relapse, if they were going to relapse, was just shy of a year. Whereas patients who received a year of interferon, their time to relapse was 1.72 years. And also the percentage of patients who at 5 years remained free of disease was 26% in the observation arm, so just about a quarter of patients, and well over a third of patients were disease-free in the interferon arm. About 10 years later, another form of interferon was developed called Pegylated interferon. This is simply just long-acting interferon. It allows you to give yourself a self-injection once a week as opposed to 3 times a week, but otherwise has the same criteria and portfolio as regular interferon. So a much larger study was undertaken for the Pegylated form of interferon, essentially the same design. Patients with stage 3 melanoma after surgery were randomized to either observation for 1 year, or the Pegylated interferon, and this time they were treated for up to 5 years if they could tolerate it. Essentially the same results. So patients who were observed, their average time to relapse was about 2 years, whereas patients who received the long-acting interferon, it was about 3 years. So the side effects of interferon, and this is the short-acting and the long-acting. Short-acting is called Intron A, and the long-acting, the Pegylated, is Cytotron. They're identical. The most common is fatigue and depression. Fever can occur. Muscle aches is very common. You essentially feel like you have a continuous flu. Loss of appetite, it can cause nausea and vomiting. It can cause elevation of your liver enzymes and decrease in your complete blood count. So as an alternative to interferon, many groups have looked at what else can we use? Is there something better? Mainly because of the long treatment duration and the toxic side effects. So biochemotherapy is another regimen. It's a 5-drug intensive hospital-based treatment that's given for 1 week in the hospital followed by 2 weeks of recovery at home. So 432 patients were randomized in this large intergroup study to receive either the 1 year of high-dose interferon or biochemotherapy 1 week in the hospital followed by 2 weeks at home. And this was continued for 3 cycles, where a cycle was considered 3 weeks. So the biochemotherapy arm was simply a 9-week regimen. And here are the results, that the patients in the interferon arm had approximately a 2-year time to relapse if they were going to relapse, and that's consistent with the prior interferon studies. However, the patients who received biochemotherapy had a much longer time to relapse if they were going to relapse. So biochemotherapy may be an option in some patients, with the caution that it's a very intensive treatment. It requires you to be in the hospital, and it can be a little bit more toxic to certain organs than just interferon alone. The benefit of interferon in patients whose melanoma begins in the mucous membranes remains unclear. And so there was a study performed that looked at mucosal melanoma patients who had their tumor surgically removed, and they were randomized to either observation or 1 year of interferon or chemotherapy using cisplatin and temozolomide. And this was also administered every 3 weeks for 6 cycles, so a total of 18 weeks. And what we see here is that the average time to relapse, so all of the patients who were observed with mucosal melanoma had relapsed by 2 years, interestingly. The patients who received interferon alpha at 2 years, about 12% of them had relapsed at 2 years, and the average time to relapse for them was 9.4 months, which was significantly longer than the patients who were observed. In Arm C, the chemotherapy arm, the average time to relapse was almost 2 years, 20.8 months, with 41% of patients alive at 2 years. So based on this, there may be patients with mucosal melanoma who's been surgically removed that may be good candidates for chemotherapy rather than interferon. One of the newer drugs on the block is Ipilimumab. This was FDA approved in 2011 for the treatment of stage 4 or advanced melanoma. And so now it's being studied in the adjuvant setting. And this is the trial design. It's an incredibly large study. 1,500 patients will be enrolled. It's currently ongoing at many sites across the country. This study is a 3-arm study looking at high-dose Ipilimumab, which is a 10 milligram dose, versus typical interferon, high-dose interferon, versus the standard or low-dose Ipilimumab, 3 milligrams per kilogram. Each of these treatments will continue for a year, and the endpoint is, again, looking at relapse-free survival and time to relapse. Another ongoing clinical trial is using Vemurafenib. This drug was also FDA approved in 2011 for advanced melanoma that harbors a mutation in the gene called BRAF. So this study aims to enroll 725 patients with either stage 2C or stage 3 melanoma after surgical removal. We have to have documentation of a BRAF V600 mutation, and patients will be randomized to either placebo for 1 year or 1 year of Vemurafenib therapy. Again, looking at relapse-free survival and time to relapse. The idea behind vaccines, I'll just briefly mention, is it's trying to boost the ability of the body's immune system to recognize and kill melanoma tumors. So there have been many types of vaccines designed. A lot of these use melanoma proteins that are recognized by the body's immune system. And there's many forms that they take, including combination with growth factors, multi-melanoma peptide vaccines, combination with boosters to help it absorb and get recognized by the immune system better, or topical boosters for that effect. Vaccines have been combined with interferon, and vaccines are being combined with Ipilimumab. Vaccine clinical trials are available across the country at centers that have expertise in immunotherapy and vaccines. So just in summary, not every patient needs adjuvant therapy, and radiation still is controversial. It's not a hard and fast rule. Interferon is the only FDA-approved therapy. Regular interferon, the short-acting and the long-acting, those are the only FDA-approved therapies for adjuvant treatment of melanoma. But biochemotherapy in the study I showed you may improve relapse rates in certain patients who could tolerate it and qualify for it. That's not a clinical trial, that's just considered standard care. And chemotherapy may also improve the relapse rates in the certain subset of patients, perhaps whose melanoma begins in the mucous membranes. The newer drugs, Ipilimumab, Vemurafenib, and vaccine clinical trials also exist, and they're available throughout the country. Thank you very much.